All this is Dr. Mobeen Sayed from drbeen.com. Welcome to one more show. So welcome back. Thank you very much for letting me have a day off yesterday. Eid technically continues till tomorrow. Tomorrow, my wife is flying out to meet her family members. So I'll request you one more day of off tomorrow so I can celebrate that she is out. So I'm just kidding. There is something that I want to do with my son. And so if you're okay, I'll take one more day off tomorrow, and then we'll be back to normal schedule after that. Having said that, Maraviroc has been something that has been in discussions, at a lot of fronts. And I wanted to make sure that we can go over the mechanism of Maraviroc. So today's discussion, we will do the following topics, or we'll go over the following topics. Number one, what are the immune system cells that can be targeted by Maraviroc? So I'll set up the context first, and then we'll look at the mechanism of action, then we'll look at the side effects, dose and side effects. So one, will look at the cells that are a target of Maraviroc. Then we will, sorry, Luffy is actually talking to a cat outside. After that, we look at which cells have the CCR5 receptor. And for anyone who feels that he is hungry, he's not hungry. He always feels like talking when I am talking. So this is his participation. He's singing the song of his people. So we look at the receptor. Then we look at the CCL5 or RANTES, because RANTES interacts with the CCR5. We'll see the actions of those. And then we look at the Maraviroc and how Maraviroc actually contributes to the immune modulation. And then how does it work for HIV virus, or kind of act as an antiviral for HIV. After that, we'll look at the dose, and then we'll look at the side effects, and we'll continue from there. So once again, thank you very much to everyone for being here. Today is a big news as well that we have France back as well. So France, welcome back, and let's start our discussion. Doug has not been here for some days as well. Margaret is out. Her phone is still not fixed. Okay, so let's start. These are the links. This is drbeen.com. This is the drug database for Maraviroc. I would love that the folks here go over the side effects of the Maraviroc. For example, yellowing of your skin or the whites of your eyes, jaundice. So that is really an indication of the liver damage or stress on the liver. Dark colored urine, that may be because of the blood in the urine. Light colored bowel movements, and that is again related to the liver abnormalities. Loss of appetite for several days or longer, nausea, vomiting, pain, aching, tenderness, itching, and general ill feeling, extreme tiredness, muscle or joint aches, fever, blistering or peeling of skin. So these are allergic reactions. Blisterings or sores in your mouth, redness or swelling of the eye, swelling of your face, trouble breathing or swallowing. So these are the side effects. And this is one of the reasons that you don't see Maraviroc as openly discussed and talked, because the side effects can be serious. Now, again, this is Maraviroc here on Wikipedia. If you like some other better resource, please look it up over there. For me, I always hit the books first, and then I look at the online systems. So here is the Goodman Gilman 13th edition. So it is a slightly older book, and this is the Maraviroc over here. And I don't want to, of course, it's a copyrighted material, so I'm just going to stop it here. But I have the reference and the location for the book in the links. So this is about Maraviroc. Then CCR5 or chemokine receptor 5 is going to be involved in the discussion. So that is here. The links are in the description. This is a G protein link that is also in the description, and we'll talk about that. This is CCL5 or chemokine ligand 5. We'll talk about that today as well. This is also RANTES. Then CCR5 receptor antagonists, for example, Maraviroc and others. Then this is also a very important one, CCR5 positive inflammatory monocytes are crucial for control of sepsis. So this is important. If you can keep one thing in your mind today, and that is to see how Maraviroc, in addition to blocking HIV, potentially blocking HIV, how can it modulate the immune system's response, especially monocytes response. And then finally, this is another important topic here. This is about the CD8 cells. Maraviroc is known to be acting on CD4 cells or helper T cells. However, there are studies that show it to be able to modulate cytotoxic T cell or CD8 positive cells effect as well. So this is that. I'm closing them down today because somehow my processor is churning. Okay, so let's start. So these are the gifts for humanity. Maraviroc. What is Maraviroc? Maraviroc is an allosteric, and we'll discuss what is allosteric later, non-competitive antagonist of CCR5 receptors. So just a quick note for these things. Allosteric mean a drug that will bind to a receptor at a place where normally the receptor's own binding substrate does not attach. For example, let's say there is a key that goes in the keyhole in a door. If there is some other way to hold the door closed without using the key and the keyhole, then that will be a allosteric mechanism. For example, if we lock the door at the hinges, or if we tie it with some other way. So allosteric mean it would attach to the receptor at some other place than the normal regular binding area. Non-competitive means that when it attaches to the receptor, it does not care if there is a competing substrate that can also attach to this receptor. It just binds there and it binds there. Antagonist simply means it would suppress or stop that receptor from functioning. I have already gone over the side effects. It can cause serious side effect. Maraviroc actually comes with a black box warning in the US, and that is for the hepatotoxicity. Although there has just been one case, but still there is hepatotoxicity with this. Now, this is a summary of the drug. Let's see how does it work. And what I would request you is to look at the immune cells. You actually all are aware of these immune cells from our previous discussions. Just look at it once more from a point of view of which cells have CCR5 receptor on them, chemokine receptor number 5, and then which receptors are producing RANTES, because Maraviroc would actually be interfering in those cells' actions. So let's see. So here, if we look at the immune system, we have innate arm and we have adaptive arm, correct? On the innate arm, we have many kind of cells and proteins, but important one for today's discussion, macrophages. Macrophages have CCR5 receptors on them, or chemokine receptor type 5. And when we are talking about chemokine receptors, normally chemokine from kinetics, receptor are those receptors which, when activated on a cell, will cause the cell to start moving towards the site of inflammation. So that is why they are called chemokine receptor. Of course, if these cells are going to move towards something, then there has to be a signal to them that will come and attach to this receptor. That signal that would attach to the receptor is called a ligand. A ligand is nothing but a binding thing that can bind to a receptor. So if there is a receptor, then there is going to be a ligand as well. So in the discussion today, please keep an eye on where are the receptors. These are in blue color. And where are the ligands, or these are in green color here. So macrophages have CCR5 on them. Dendritic cells, which are kind of another kind of macrophages. I'm using it loosely. They also have CCR5. I'm using this term loosely. Natural killer cells, which are actually lymphocytes, which have broken away from the adaptive arm and have joined ranks on the innate arm, and they work there. So natural killer cells actually have CCR5 as well. And remember, we've talked about them. They're kind of a pervert cell that they would touch every other cell. They're a good cell, actually. I'm saying it pervert so that you remember them. They touch every other cell, and if the cell is sick, they would kill that cell. These cells, natural killer cells, also have CCR5 on them. Monocytes, and monocytes are important for today's discussion. I guess you know why. It is because of many of the pathologies that nowadays we are seeing. So monocytes have CCR5 on them as well when monocytes are active. Usually inactive monocyte or resting monocytes do not have CCR5. But when they are in a specific functional states, then they can have CCR5 expressing on them. That means they become a target of the drugs that modulate or inhibit CCR5 receptors. This is a beautiful thing to keep in mind. So this is a very important thing for today's discussion to keep in mind. Then we have on the innate side, we have neutrophils as well. They do not have CCR5 on them. In addition to these cells, there are eosinophils, microglia. Microglia are nervous system cells. Eosinophils are also immune system cells. Then when there is a cancer of breast or prostate, those cancer cells that start metastasizing, that start moving, they develop CCR5 receptors on them. And when CCR5 receptors are triggered, when they are stimulated, these cells move. So that is an interesting and important key thing to keep in mind as well from cancer's point of view. Now, this is the innate arm. On the adaptive arm side, we have seen these cells as well. And there is the important part. These T cells, helper T cells, are important for today's discussion because they are the primary target of Maraviroc. And how do they work? So we know that we have naive helper T cell. Helper T cell, all of them have a protein on their surface called CD4. All helper T cells. So I remember it this way, that I am here for helping. So they have CD4 or cluster of designation 4 on them. Helper T cells also have CCR5 on them. These two receptors, you will see a little down the road in the discussion today, they are important for the HIV virus because HIV virus has a spike protein, just like SARS-CoV-2 has a spike protein. That spike protein binds with these two receptors to then allow the fusion of the virus to occur with the cell membrane. Its spike protein has a very similar behavior like SARS-CoV-2 spike protein. For example, SARS-CoV-2 spike protein, one part of that binds with the receptor, then the other part fuses with or binds with the cell membrane and allows the virus to fuse with the cell membrane. That is the same behavior over here. The only thing is the receptors are different and the proteins are different. In case of the HIV, one protein part connects with CD4 and then CCR5, and then the second fusion part helps the virus to fuse with the cells. So CD4 naive cell, that is 0, that can be a target. Then we know that T helper 2 cell is basically a naive cell when it becomes a T helper 2 in the presence of interleukin 12, absence of interleukin 12 and presence of interleukin 4. And this T helper 2 cell also has, of course, CD4 on them. All helper cells, T cells, have CD4 on them. And they have CCR5 as well as on them. And they produce RANTES as well. Now, what is the importance of RANTES here? RANTES or CCL5, CCL, chemokine ligand 5. The role of the ligand 5 is to actually bind with the receptor. So let's say this cell, if it makes RANTES, this RANTES can attach to its own receptor, or it can attach to other cells' receptor, or it can attach to the cells here. It can attach to many cells' receptors and activate them. So it is possible that a cell will produce RANTES and activate its own self because it also has RANTES receptor, or which is called CCR5. So back here, we know that one pathway is T helper 2 pathway. Then there is also T helper 1 pathway as well, which is taken in the presence of interleukin 12. And we know that T helper 1 also have CD4 on them. They also have CCR5 on them. They also secrete RANTES or CCL5. So the point of this is that immune cells, not only they move to the area of inflammation under the calling of CCL5, but they also can release CCL5 to call more immune systems over there. This is as if, let's say, there is a war going on in a place and the soldiers go there, and the soldiers who go to the war zone, from there they call in more soldiers there. So these soldiers can respond to the calling, plus they can call more soldiers. This is what is happening, that every T cell, helper T cell, can call more cells over there, plus when the RANTES is present, CCR5 allows them to go to that area of the war. Now, then we have B cells on the T helper 2 pathway. B cells, when the T helper 2 is present and interleukin 4 and 5 is released, we know that the B cell will convert into a plasma cell. We've done these discussions almost a whole year. And this plasma cell over here will make antibodies, and that is an immune function. So imagine if CCR5 is blocked here. You can imagine that this pathway would reduce a little bit. Or if it is blocked here, then this pathway will reduce a little bit. That is immune modulation. And any drug that would block these receptors will modulate the function of these cells. So you can actually see here in this one map all those cells that may become a target of Maraviroc. Maraviroc blocks CCR5. So macrophages can be modulated, dendritic cells can be modulated, NK cell function can be modulated, monocyte cell function can be modulated, T helpers can be modulated, not B cell. But because T helper is modulated, that in turn will have less effect on the B cell conversion. Similarly, when T helper 1 is active, what it does is it activates cytotoxic T cell or CD8 T cell. Normally, CD8 T cells do not have CCR5 on them. But as I showed you the study in the beginning, some of these have them. Okay, so now we know the map of where CCR5 is present. And why CCR5 is important, because the drug we're talking about, Miraviroc, is going to block the CCR5 receptors. So now what is the CCR5 receptor? It is a chemokine receptor 5. It is present on the gene for it. So of course, every protein, every receptor, every structure that is made has a gene somewhere in our DNA that would have the recipe to build this structure. So on our chromosome number 3, on the small arm of the chromosome, or petite arm, or petit as in French, P arm, the location number 21 has the gene that helps make CCR5 receptor. Interestingly, there are some people, some of us, have a mutation in this area, which, if it is homozygous, homozygous means there are 2 copies of the gene. If they both have the same mutation, then we become sort of less prone to HIV. This is just like we see with SARS-CoV-2, that it mutates its spike proteins, and it is trying to kind of evade our response to it. Similarly, our system also does mutations. So there are people who have mutations on this location, which, if present homozygously, then it makes them a little less vulnerable to HIV. Anyways, back here, this area is the gene for the CCR5. CCR5, when it is created, we say it is a G-coupled protein. So we take the CCR5 receptor, we then attach a G protein to it. It's another receptor protein. It's part of our cell's function. Many of our receptors are made up of G proteins, or they're coupled with G proteins. G proteins over here, if you can see, are also called serpentine protein or snake-like proteins. Why are they called that way? A G protein has 7 pieces to it. 1, 2, 3, 4, 5, 6, 7. 7 transmembrane domains. or seven, imagine 7 little sticks that go through the wall of the cell, the membrane of the cell. Outside, it is the CCR5 receptor. And across the cell membrane is the G protein. That is why we say it is coupled with the G protein. Now, this CCR5 receptor, when it is going to bind with a ligand is nothing but something that can attach to this receptor and stimulate it or inhibit this. Then there will be a secondary reaction in the cell and some function will occur. That is the CCR5. A CCR5 receptor can bind with CCL3, again, chemokine ligand, a signal that would attach here to ask the cell to move. So imagine if you ask me to move, and you can give me a signal by verbally saying it to me. So then my ears are my CCR5. And if you say, Mubin, move, then that order that is coming in is the CCL or chemokine ligand. That is a binding thing that would bind to the ears, and then I'll move. So here, CCL3 or CCL4 or CCL5, which is also called RANTES, they all can connect with CCR5, and then some action would occur inside the cell. So this is the function of the receptor itself. Now, what are the kind of functions that can occur? The cells can start moving, and we saw that breast cancer cell or prostate cancer cells, when their CCR5 receptors are stimulated, these cells start crawling around, metastasizing, and going to other parts of the body. Then immune function, they can cause, when this receptor is stimulated, it can cause an immune cell to start moving towards the area of inflammation or to do other actions as well. Then we also know that CCR5 is a co-receptor for HIV virus, which is HIV-1 strain 5. Now we know what variants are. So HIV also has variants. So there is a variant called variant number 5 or strain number 5. That strain can actually bind with CCR5. And I'm going to explain that in the next slide. So these are some of the roles of CCR5. So let's continue. Let's look at the RANTES itself, the CCL5. The ligand, the stimulant that would attach with CCR5 and cause some reaction in the cell. So what is that CCL5? So that is the order coming in. So why is it called RANTES? It is called RANTES because it stands for, or it is the abbreviation for, regulated on activation, normal T cell expressed and secreted substance. So RANTES is expressed or made and secreted from the T cells, which are normal T cell, and this happens when the activation of the T cell occurs. That is what it stands for, RANTES or CCL5. Now, if you see here, what happens is CCL5, as I just discussed before as well, it is a chemotactic factor for T cells, that means helper T cells mostly, eosinophils, that is the innate arm cells, basophils, also immune cells, NK cell, natural killer cell in innate arm cells. When their CCR5 is stimulated by CCL5, these cells proliferate, that means increase in number, plus they become active. And then, interestingly, if someone is infected with HIV, in some people, their CD8 cells, CD8, I'm not talking about CD4 anymore, their CD8 cells try to make more RANTES so that they can cover their own and other cell CCR5 to kind of defeat the HIV virus from attaching to these receptors. This is equivalent to, nowadays, SARS-CoV-2 is more common discussion. So if I said that, imagine a cell has ACE2 receptor on it, and when the cell detects that my ACE2 receptors are becoming occupied by SARS-CoV-2 again and again, then the cell starts making a substance that can occupy its own ACE2 so that SARS-CoV-2 cannot attach, and that is the defense mechanism of the cell. This is the kind of mechanism that HIV infected CD8 cells do in some people. And so they release RANTEs to go and attach to CCR5. Okay, so now we also know what is CCL5. Now let's look at the HIV virus. HIV virus is also, it's a retrovirus. It is also an enveloped virus. What is important for us today to understand is that it has a spike protein as well, just like SARS-CoV-2 has a spike protein. This spike protein that HIV virus has many flavors to it, has many mutations to it. Just like SARS-CoV-2 continues to make mutations, HIV virus makes mutations as well. And you saw that our own cells make mutations too. So mutation is a standard process of viruses, bacteria, and our body. So here, this spike protein for the HIV has a structure like this. It has a central unit, protein unit, that crosses its cell membrane of the virus, or envelope more correctly. This unit is called GP41, glycoprotein number 41. Then this unit has attachment of 3 more units to it. These 3 units are outside of the cell membrane or envelope. They are attached to the GP41. These 3 units are called GP120. And together, this whole structure is called GP160. Or just like SARS-CoV-2 has a spike protein, we call it S protein. In case of HIV, the spike protein of the HIV is called GP160. Now, what happens is, just like SARS-CoV-2, we have an S1 unit and an S2 unit. S1 unit binds with the ACE2 that allows the S1 to become trimmed away, and the S2 becomes available, which is like a knife or a drill, which would then go and grab onto the cell membrane and then allow the virus to fuse there. It is a similar thing over here. GP120 will attach to CD4, which was in the helper T cells, plus CCR5, which is a chemokine receptor we're talking about. And when that binding occurs, that causes this unit to go away, or to set aside, or to have a conformation change, that it opens up and then allows this central unit, or the GP41, to attack the cell membrane, fuse with it, and then allow the envelope of the HIV to fuse with the cell. That is what it does. So very, very similar to SARS-CoV-2. And also, please realize, many enveloped viruses have these spike proteins, and they do behave this way. This is why we have standard antiviral category, that is entry inhibitors or fusion inhibitors. So it is not just for HIV or just for SARS-CoV-2, and it is not that they are somehow similar, so that means SARS-CoV-2 is like HIV or is HIV. That's not the case. Many enveloped viruses have spikes on them, and they use the spike in a similar way to fuse with the cell membrane. Okay, so knowing this much, let's now see the same mechanism that I just described. Here is a diagram. Imagine this is a virus, HIV. Its 120 unit connects with CD4. That is the first binding. Just like on our, in case of SARS-CoV-2, so I'm now discussing 2 viruses in parallel. If you look at SARS-CoV-2, the spike protein first binds with ACE2. Then our TMPRSS2 primes it, and then the fusion starts, correct? Similarly here with the HIV's GP120 connects with CD4. This is a helper T cell. When the CD4 is connected, then there is conformational change in GP120, and it opens up a little bit and attaches to the nearby CCR5 receptor. This is the co-receptor model, where the virus's spike protein is attaching to 2 receptors instead of 1. Imagine if SARS-CoV-2 connected with ACE2 plus some other receptor as well. That is a kind of model here with the HIV. Once the GP120 binds with these two type of receptors, that then opens up the central part of the spike protein of the virus, HIV virus, which is the GP41, and it allows that central part to fuse with the cell membrane and then cause the virus fusion with the cell. So before I continue, check this out. Don't you think that if there is something that can block CCR5, if there is something that can interfere with CCR5, then it will become difficult for the virus to fuse with the cell membrane. Just like in the case of SARS-CoV-2, we say that if there is something that can block TMPRSS2, then the priming of the spike protein will not occur or will be less in number. So less viruses would have priming done, and that would reduce the entry. It's a very similar thing, but TMPRSS2 is a priming system. Here we just need two receptors. Okay, so once both receptors are occupied by GP120, then GP41 will connect with the cell and allow the virus to fuse. Okay, so here the fusion has occurred. This blue thing is the virus's membrane. Virus has given its RNA inside the cell. For the HIV, although discussion today is not about HIV itself, but what happens is once the RNA of the HIV is in our cytoplasm, its behavior is different from SARS-CoV-2 RNA. This RNA will create a complement DNA piece. That DNA piece will go in our nucleus, will become integrated into our DNA. Then when our T cells are becoming active because there is an infection and they need to function, so when they will function, that integrated DNA would continue to make viral proteins as well. And that would make more viruses. So that's the tricky and clever thing that HIV virus does. In this whole process, that virus continues to kill CD4 cells as well, and in a way brings down the immune system itself. Now, continuing on, what do we mean by allostatic binder? So now we are at the Maraviroc. What Maraviroc does is it binds with the CCR5. So here it is bound here. Now when the virus is going to try to connect with CD4 and with CCR5, CCR5 is already occupied with Maraviroc, and that would defeat the viral fusion, and that would reduce the viral entry into the cell. So we are talking Maraviroc now. So then the question is, what is the dose? So absorption, distribution, metabolism, and excretion of Maraviroc or ADME. Maraviroc is the only anti-HIV antiviral that has been approved in 3 doses. It has a dose of 150 or 600 or 300, but there are conditions. Conditions are if the patient is taking any other drug that can be a CYP3A or cytochrome P450 3A enzyme inhibitor, and most of these enzymes, cytochrome P450 enzymes, they are present either in the liver or in the intestine or in both places, not either. They're present more abundantly in the liver and intestine. And if you remember that initial cartoon that I had made, where there was this little chef thing which had a fire in its hand, the CYP450, its function is to oxidize various medicines or foreign molecules. Let's say it in our simple terms that it burns them. So if a patient of HIV is taking some drug that causes CYP or cytochrome P450 enzyme to be less active, then a smaller dose of Maraviroc is needed, because CYP450, Maraviroc is a substrate for that enzyme. And now that enzyme is inhibited by other drugs, so we need to reduce the dose for Maraviroc as well. So 150 milligram BD twice a day. If patient is taking some drug that is inducing the CYP for 3A, 453A. So over here, 450 is implied. CYP 453A. If there is an inducer, then a higher dose is needed. So 600 milligram BD twice a day. Then other concomitant drugs, if they are being taken by the patient, then it is possible that the dose needed is 300 milligram BD. It is taken orally. It becomes available about 23% to 33% of the oral dose becomes available in the body. And it depends upon the dose. For example, a greater dose makes a greater percentage available. So it is not that all doses have 23% available of the dose. If you have given a greater dose, then the percentage that gets absorbed increases as well, and it can go up to 33%. So now, what are the side effects? So I hope it is clear what is the mechanism of action of Maraviroc. Maraviroc binds allosterically with the CCR5 and disrupts the inflammatory process and disrupts the HIV virus's entry into the cell. So side effects, it is well tolerated generally. However, it can cause orthostatic hypotension. That is, when somebody stands up, their blood pressure might drop because the heart cannot keep up with the blood pressure because the blood vessels are dilated or not active correctly, and the blood gravitates towards the feet. Less blood goes to the brain, and then there is a feeling of disorientation and dizziness. So orthostatic hypotension can occur in at least one case according to the book. So that book is 2016 version. We are in 2021, so there may be more. But from that book's, one case of hepatotoxicity has been observed, but we know generally Maraviroc can cause stress on the liver. And finally, we also know that Maraviroc is a substrate for CYP 453A. So 3A4. And so here is the Maraviroc sitting with this chef. This chef's role is to oxidize other substances. Maraviroc does not induce or inhibit this, but it does bind with it. That means other drugs' actions can become affected. And this is why if you're taking other drugs, or if somebody is taking other drugs that need to work with this enzyme, then Maraviroc's dose need to be increased, reduced, depending upon the drug. And one more important thing, there is another enzyme, which is the CYP2D6. When Maraviroc is taken, this is for healthcare workers especially, when Maraviroc is taken at 600 milligram dose, BD, then it can cause Drbeen drug to become affected by the other liver enzymes. So this is the discussion for today. What is the takeaway? Just a very quick summary. Maraviroc is a drug that is approved for HIV, especially HIV-1 strain or variant 5. Mirovirok can bind with CCR5 and disrupt the entry of the HIV virus. In addition to that, Miravirok can work with the CCR5 to modulate the immune system's response. Specifically, a more interesting one nowadays is the monocyte response, which may be interesting for SARS-CoV-2 long haulers. It can actually reduce the inflammation by reducing chemokine behavior or by reducing the chemotactic behavior. It can be useful in breast and prostate cancers as well. Again, there are still researches going on to see the toxicity versus the benefit is to be seen. So this is the drug. I'm just going to see if there are any quick questions. Otherwise, we'll do a quick chit chat as well. Colin says, would the same treatment work with the cancers? Possibly yes, but they are still doing research on the doses needed for breast and prostate cancers. So System says they have an NNTV question about the vaccines. I want to continue on with the Maraviroc for this topic. We can do chit chat and talk about those things. France says, love the chef, Dr. B. Thank you very much. And France, welcome back. We have been, all of us, missing you. So Rima says, this talk is going over my head. So one last time, it's actually very, very simple. I probably just was talking about the receptors and became a little complex. Very simple. T cell, helper T cells, have CCR5 on them, receptor. When that receptor is activated, that activates the T cell. So if we want less immune responses or less inflammation, what do? We want to suppress the T cells. So instead of giving a steroid, you might give Maraviroc. Maraviroc would go and attach with the CCR5 and reduce the activity of the T cells. It's similar to leronlimab as well. So that is one action. The second action is that HIV virus uses CCR5 to bind as a receptor. And when Maraviroc is attached to the CCR5 receptor, then HIV virus cannot bind easily. So that is another. And then the third one is in cancers, where Maraviroc can reduce the metastasis of the cancer cells by reducing their movement. So that is a kinetic behavior of chemokines. So I hope that helps. Okay, cool. So let's do this. I'm gonna hang up now and then come back live for a quick chit chat as well. So please like, subscribe, and share. And if you would like to support this work, there are 3 links in the description. You can buy me a coffee, or you can be a patron. I love it if you are a patron, because then you can support this work for other healthcare workers and students as well. Or you can use PayPal as well. So those links are present in the description. Thank you very much. I'm going to see you in a few minutes in the chit chat.